morning, good afternoon to everybody. I'm so pleased to be here today at the CIHR Canadian HIV Trials Network Postdoctoral Fellowship Awards. It is truly one of the highlights for the CTN every year. Today I'm speaking to you from Vancouver, and I'd like to acknowledge that I live, work and play on the traditional and unceded territory of the Musqueam, the Squamish, and the Tsleil-Waututh people. I would also like to recognize that we are gathered here from all around the country, as well as internationally, and each of you are on a different traditional territory, and I'd like to acknowledge that as well. I'm joined by a lot of people here, our postdocs, and also I'm joined by my two co-directors, Dr. Klein and Dr. Walmsley, as well as Jackie, and welcome to all of you. The CTN Postdoctoral Fellowship Awards are a showcase of one of the most important aspects of the work we do to train future researchers who can continue to answer important questions for the community we serve. In its 29 years, the CTN Fellowships Award has allocated more than 165 awards to over 100 fellows. That's a lot of fellows and a lot more awards. This includes one international fellowship every year, which is awarded to a scientist in a resource-limited country. By the way, there isn't one this year, but it's just for this year, and it's an anomaly. After nearly 3 decades, we have really seen the fruits of all this labor come full circle. Many of our leading scientists at the CTN today were originally our postdoctoral fellows, including one of our co-directors. And now, in turn, they're mentoring the next generation. And one thing that is really important and unique about this meeting is that we are going to recognize one person that has been instrumental in the success of this program. A lot of you know her as Mama. After 30 years at the CTN, Jackie Sass will be retiring. In a few weeks. She has been the heart of the CTN since 1990 and has been leading the postdoc program since its inception. So Jackie has always been passionate about this program, even taking upon herself to act as the liaison for raising money to support the program. Because of her enthusiastic personality, powers of persuasion, she was able to connect with pharmaceutical companies that were involved in the development of HIV drugs to get them to give additional support to the program. And in this way, the program is able to offer even more postdoctoral awards than our government funding allows us to do. As most of you know, this is Jackie's last CAHR meeting with us, but her legacy has transformed lives around the world and will continue to do so for decades to come. Jackie, we will miss you and we wish you the best of luck in your retirement. I hope you received our package a couple of days ago and you're enjoying that. And you will see so many people are so much missing you already and are thinking about you all the time. And actually, we are also working on a plan that expands the postdoctoral program and memorializes important contributors to the program like yourself. So stay tuned for some announcements in the near future how we do that. And with that, I'd like to ask Jackie to say a few words unrelated to the announcement of the postdocs and then announce the postdocs.
Thank you, Aslam, for your really warm welcome and send off. I had my speech already all rehearsed, but I guess things happen in life. So so it's been really an incredible privilege to work with all the postdocs. I had written a few words so this is a special moment for me. After 31 years with the CTN, I'll be starting a new adventure as a young retiree. I will keep in my heart fond memories for all the interactions I have had with the postdoctoral fellows former and current, over the years. Thank you to Aslam, Sharon, Marina, Marianne, and Kristen, and the chair and the CAHR organizers for their support. I leave behind a robust program which I hope will continue for many years to come. It's been a privilege and an honor to learn, to work, and sometimes play with all of you. So those were my words, and you cut me a little bit short, but then, then that's life. Thank you, Aslam, very much, and thank you all for for all the incredible adventure it's been these 31 years with the CTN and all my colleagues. And the successes of the postdocs are for me give me a sense of pride and accomplishment. So I learned from you, and I'm glad that I am pushy and I got the money. Thank you.
Jackie, can we just let Marianne say a couple of words before you talk about the new postdocs?
Sure.
Thanks, Sharon, and great to see you, Jackie, virtually as always. I'm always impressed with how tidy everybody's offices are, by the way. Sorry about the mess behind me. Anyway, I wanted to say that I'm speaking now both as the chair of the Postdoctoral Fellowship Adjudication Committee, but also some of you may not know that I have some historical significance here because I was lucky enough to be the recipient of the postdoctoral fellowship in the first year of its inception, along with Jean-Pierre Routy way back in 1992. I was one of the first CTN postdocs. And, you know, since that time, as Aslam mentioned, there have been well over 100 postdoctoral fellows who are now, many of whom are now leaders in their field, working across the country. And it's really been Jackie as the driving force that has kept this program as strong as it has been, as impactful as it has been. Her relentless pursuit of funding for this program has really made all the difference and kept things going. And as I'm sure she will announce, that it's nice in her last year, we're actually able to give out a record number of new postdoctoral fellowships this year. So a real credit to all her fantastic work. And in recognition of her legacy in getting this, keeping this program as active and thriving as it is, there's talk underway of having in the future, starting next year, having one of the postdoctoral fellowship positions named after Jackie. And I think that's a very appropriate recognition of her legacy. And all her efforts, of course, will be greatly missed. It's not the only thing she does at the CTN is running the postdoc program. I think we all remember the many years during which Jackie really organized all the CTN meetings, and you know, such a hard worker in so many ways. And just on a personal note, Jackie, it's been a blast working with you. Always, always enjoy it. It can be so greatly missed. And just all the best for health and happiness to both you and Gabby in the years to come. So great to see you. Take care.
Thank you very much. So I'm going to just start just to tell you the exact numbers. We've supported 174 awards in 107 individuals. And it's true that we've blown all records by supporting 11 fellowships out of the 12 applications we received. I have to ask your patience because we would not have been able to allocate 11 awards without the support from our generous sponsors, CanFar, Gilead Sciences Canada, Vive Health Canada, and Merck Canada. Un grand merci pour votre soutien. Many thanks for your support. Your contributions guarantee that HIV, HCV, STTBI research remains healthy and vibrant in Canada. So without further ado, the recipients renewed for a second-year salary are Dr. Elizabeth King, who received the Mark Weinberg Fellowship, Elizabeth is an MD with infectious disease specialty at the Faculty of Medicine, UBC. She is supervised jointly by Drs. Melanie Murray and Mona Lutfi. Dr. Stefan Isnar, he is a PhD in immunology, and he's supervised by former postdoc Jean-Pierre Routy. Dr. Elizabeth McClement, she is the CAHR CTN recipient, and she has a PhD in reproductive and developmental sciences. She's supervised jointly by Isabel Boycan and Soren Gant, Faculty of Pediatrics at UBC. Dr. Adria Quigley, she's supported by Gilead, and she has a PhD in health from Dalhousie University. She's co-supervised by Marie-Josée Bruyette and Nancy Mayo at McGill. The new fellows to receive a salary award is Dr. Alice Sabokiritsky. She's the recipient of the James Grepner Award. She is an MD with a specialty in infectious diseases. She will be supervised by Dr. Sharon Wamsley at UHN Toronto General University of Toronto. Her project is evaluation of healthy aging among people living with HIV in Canada through multidimensional domains of health and aging. Dr. Katia Guiguer, she receives a CTN fellowship. She has a master's in microbiology and immunology and a PhD in epidemiology. She will be supervised by former postdoc Madeleine Durand at Montreal University. Her project is cardiovascular disease among people living with HIV, identifying novel screening tools and potential targets for early diagnosis and treatment. Dr. Cara Spence is the recipient of the CAHR CTN Fellowship. Cara obtained her PhD in global health from the University of Saskatchewan. She will be co-supervised by former postdoc Marina Klein and from McGill University and Dr. Stuart Skinner from the University of Saskatchewan. Cara's project is under the covers the truth and reconciliation of HIV infection among Indigenous women in Saskatchewan. Dr. Jordan Sand received a CTN fellowship. Jordan obtained his PhD at the University of Pittsburgh, Graduate School of Public Health, Behavioral and Community Health Services. He is co-supervised by former postdoc Nathan Lachowski, University of Victoria, and David Moore from UBC. His project is to assess the impacts of COVID-19 on influence endemic production from July 2019, pre-COVID, to August 2022, 6 months period follow up to 4 years, to determine associations between endemic conditions and HIV-related health services in Vancouver. Dr. Joshua Edward receives again a CTN fellowship. He has a PhD in social ecology from UBC. He will be supervised by former postdoc Troy Grennan at BCCDC. His project is to examine the knowledge, attitudes, and beliefs of gay, bisexual, and MSM and trans women, including individuals living with and HIV negative, around the role of doxycycline for bacterial STI prevention in sexual behavior and its impact on STI testing and treatment. Dr. Lena Royston, she receives a CTN fellowship. Lena holds an MD and a PhD from University of Geneva. She's supervised by former postdoc Jean-Pierre Routy at McGill University. Her project is co-infection with herpes viruses in the antiretroviral therapy era, influence on comorbidities and inflammation. Finally, Dr. Serge Vicente receives the CTN Postdoctoral Fellowship. He has obtained his PhD in statistics from Montreal University and will be co-supervised by former postdoc Bertrand Leboucher and Joseph Cox at McGill University. His project is developing methodological and statistical expertise in pragmatic trials for HIV research and application in the assessments on health effectiveness to enhance HIV care. thank you again for your participation, and certainly hope that you keep an eye on CTN's website, the YouTube channel, Twitter, and Facebook. I would like to acknowledge once again our sponsors, the Postdoctoral Adjudication Committee, my colleagues at the CTN, for their constant support and hard work. So each presentation will be for 10 minutes with 5 minutes in QA. We will start the presentation with Dr. Richard Mwamba Kabuya. He comes from the University of Pretoria and will be presenting on antiretroviral therapy program outcomes at Sentakana Clinic in Lesotho, a 4-year retrospective study. Thank you very much for all your hard work.
Good day. My name is Richard Kabuya. I'm a medical doctor. I'm working in Lesotho. Today I'm going to present on antiretroviral therapy program outcome at Sankatana Clinic, Lesotho, a 4-year retrospective cohort study. This study was supervised by Professor Lena Royston from the University of McMaster and by Professor Alfred and Dr. Simba from the University of Pretoria. Here is the outline of our presentation. We'll discuss about the background, objective, method, result, study limitation, conclusion and recommendation, and acknowledgement. Lesotho is a small country with a population 2.2 million. Despite its small population, Lesotho has the second highest HIV prevalence in the world. You can see Lesotho is there. This is a small country. It is there. It's located in South Africa. High level of poverty coupled with HIV and AIDS has led to lower life expectancy of 52 years for male and 55 years for women. According to UNAIDS 2020, there were 340,000 people living with HIV, and the prevalence of HIV in the country was at 22.8%, and there were 11,000 new HIV infections, and there were 4,800 AIDS-related deaths, and there was 65 and 71% of adults and children on antiretroviral therapy in 2019. The aim of this study was to evaluate treatment outcome of HIV positive patients on AD after 48 months of initiation. And the specific objective was to describe the profile of patients initiated on AD from the 1st January to 31st December 2014. And the second and the third one was to determine factors associated with virological failure and adherence at 48 months after initiation. Lastly, the last one was to determine the factor associated with outcome during the follow-up period. This was a retrospective cohort study of patients initiated on AD from the 1st January to 31st December 2014, and the study was conducted at Sankatana, which is a center of excellence in TB and HIV in the country. As you can see, this is Sankatana outside. Those are the patients, HIV positive patients, they are waiting to collect the ARV at the pharmacy. And this study was approved by Lesotho Ministry of Health, Research Ethics Committee, by the University of Pretoria, the Faculty of Health Science, and by Sankatana Management Team. Data was extracted from AT-CAT and CAT register. Data collection form developed using APM4 version 7. Factor associated with viral load, adherence, and outcome was determined using chi-square and logistic regression. And the viral load suppression was considered when the result is below 1,000 copies per milliliter. Adherence was measured as good or bad. Good when the result based on the pill count was above or equal 95%, and less or equal 105 based on the pill count. And good was measured when the result based on the pill count is below 95% or above 105%. And the treatment outcome was measured as retention, alive, patients who are alive and on treatment, attrition, patients who are dead, who are lost to follow-up, who stopped treatment. But lucky in our cohort, we did not have patients who stopped AT. And starter version 13 was used for data analysis. Data collection form was developed based on WHO AT cohort analysis form, and we have collected data on demographic and clinical characteristics. Study result, you can see that we have enrolled 6 604 patients were initiated on AT from January to December, and majority were female, and 54.6% were married. In our study participants were married, and 49.5 were from age below 35, and 59% was WHO clinical stage 1 and 2, and 9% did register from PMTCT, 77.5 got isoniazid for prevention of tuberculosis, and 18% were co-infected with TB, and 91.2 did receive cotrimoxazole as for prevention of proteinistic disease, and 4.6 were screened for STI. This slide shows the viral load testing uptake. You can see after 6 months of initiation, there were only 1.7% of viral load testing uptake, and in 2015 almost 38.0, and 2018 it was 83.7. If you look, see here in 2014 it was low. That's because at that time in 2014 viral load testing was done only for a specific group of patients. So meaning at that time we are collecting viral load only for a group of patients like PMTCT patient whom we suspect viral failure. As you can see, it is low, and in 2015 the government released a new policy whereby we need to collect viral load for all patients every year based on the WHO guideline and the national guideline. As you can see, there is an increasement of viral load testing uptake. This slide shows the viral load suppression from after 6 months, 2014, 16, 17, 2014, 15, 16, 17, 18. If you look, is almost above 90, and this is a good result for the country. This is a good result for the center, which is a center of excellence in HIV in the country and the referral center in the country. This slide show the adherence. You can see at 6 months and 12 months, adherence was not good. You can see it was not good, but with more counseling support, psychological support, you can see 2016, 17, 18, adherence was good. And this slide show the retention in this cohort. You see it's 90.5, 93, 90, and you should look at when you do the average, you can see that retention is good. It is above 90%, and which is a very good, because the national retention the retention is playing between 70 to 75, but this one is above 90%. This is a good result for Sankatana as a center of excellence in HIV and TB. This slide we are going to examine. This slide shows multivariable analysis of viral suppression associated with demographic, where we can see that none of the demographic factor has a huge impact on viral load. Here you can just see that here CD4 at initiation was a predictor of viral load using chi-square. And this one multivariable analysis, where we are analyzing adherence and factor, demographic factor and clinical factor. There is none of demographic factor were associated with adherence. The same here, none of clinical factor were associated with adherence. But here you can see that marital status is associated with our treatment outcome. Married patients were less likely to drop from the treatment. And this one, you can see that none of the clinical factor had a huge impact on our treatment outcome. And study limitation. First, we have used data that was collected, and there was some missing variable like CD4, viral load, height, and we couldn't even calculate the BMI BMI, and there was the state of those patients who were lost to follow-up is unknown, and patient who was dead, we don't know if the death was related to HIV or to other things, any other disease or accident. As a conclusion and recommendation, viral load suppression, adherence, and retention were generally good among this cohort at 48 months, and the ART program is successful. Married people were less likely to drop from the treatment, and you can see that CD4 count at the baseline was found to be a predictor of viral load suppression at 48 months in invariant analysis. As a recommendation, adherence counseling between 6 and 1 year should be intensified, and we need also to strengthening of tracing system in order to reduce patient loss to follow-up. Also, we need to work hard on the quality data management, quality of data, so that we can avoid missing data or missing data from when patients are coming. We need all to collect all data from the patient. Thank you. This is the last slide. I'd like to say thank you to the CTN staff for the support and help taught this fellowship program. Merci beaucoup. Merci Jackie. Thank you. Merci. Bye-bye.
Thanks very much. Merci, Tivani. We should mention that if there's questions that people have for the presentations, that they could put them in the chat and we could read them. I don't know if because we can't see everyone, so raising hands doesn't necessarily work. So I don't see any questions in the chat now, but I just want to say congratulations on your study. It's quite a large number of people that you included, and I was curious because it did seem like there was quite a marked increase in adherence as you went on in time, less at the beginning and more at the 24, 36 month time periods and beyond, which is usually the opposite of what we see in many real world settings. Was there an intervention that you introduced that helped that adherence rate go up?
Thank you so much. When patients are starting ARVs treatment, when they start ARVs, we are trying to book them every month. They are coming every month, and during the monthly visit, we give them a psychological support. We advise them the side effect of the medication. So from the beginning, it's a bit challenging, but day after day, monthly, then they get used to the medication, then they are there very well. And that's the first thing. The second one, we have a couple of NGO that are supporting us. They are sending, we have something like a 20 counselors that have been hired by some NGO. They are supporting the clinic in terms of counseling the new patient. As you can see, from 6 months to 6 months to 12 months, it was not good, but at 3 years now, the advance was very excellent.
Yeah, excellent. And,
it's Sharon. I have a quick question is, why did you elect to use a viral load of 1,000 as suppressed as opposed to something lower?
Yes. So according to the guideline, the national guideline, we are using 1,000 like a cutoff. But in the next 6 months, I think we are going to reduce it with the new guideline that will be released soon.
Sure.
Go ahead, Sharon, you're muted.
I think if you have that data and you can look at a different one, I think that will support your hypothesis, particularly because your adherence was quite high at the adherence was low and yet viral suppression was high. And so there may be quite a difference, and it may be at the early phases, they were hovering around 500 or 1,000, and maybe as you got better adherence, you're getting under 50. I think it will help support your data if you can do that analysis.
Okay.
And just one perhaps last question. It's quite interesting that finding about adherence being less likely among married people. Do you have an explanation for that? Is it due to disclosure, or is it, do you have a reason for that?
Thank you. I think the disclosure play a big role on the outcome, because most of the married, they are coming, both the wife and they are coming to the hospital together. So that can influence the good adherence that we have noticed and the good treatment outcome.
Okay, well, thank you very much for a very clear presentation, and congratulations on your work. We'll move on to the second presentation, which will be given by Richard Mwamba Kamuya, antiretroviral therapy outcomes in Senpanka Clinic in Lesotho, a 4-year retrospective study from South Africa.
I'm the one who just
the next presentation is Hanisha.
Presentation 2, that's fine. Presentation 3? I know, I was wondering, I see your name there, but the list is different. Okay, we'll go with the third one, sorry. Effects of folate deficient diet on fetal development when pregnant mice are exposed to dolutegravir in combination with emtricitabine and tenofovir, which will be given to us by Hanisha Moran, who's a CTN CIHR Postdoctoral Fellow from the UH and University Health Network in Toronto.
Good afternoon. Thank you for all attending the CAHR Virtual Meeting 2021. The title of my presentation is Effects of Folate Deficient Diet on Fetal Development when Pregnant Mice are Exposed to Dolutegravir in Combination with Tenofovir and Emtricitabine. Before I begin, I do not have any financial disclosure or conflicts of interest with the material in this presentation. In 2016, dolutegravir, DTG, an integrase strand transfer inhibitor, became the WHO first-line regimen for all people living with HIV, although a caution was noted about the lack of sufficient data of DTG use in pregnancy. In 2018 and late in 2019, a study in Botswana reported a higher incidence of neural tube defects in pregnant women who started treatment with DTG from conception. Surveillance is ongoing and new data from women exposed to dolutegravir are consistently being collected. However, many of these studies are limited by the small size and the number of pregnant women exposed to DTG from conception. The complications from the same patient may be reported in multiple cohorts, and unreported data on the occurrence of neural tube defects among stillbirth and aborted fetuses may not have been reported. As we all know, our body transforms dietary folic acid into folate, which mediates normal neural tube development. But recently, the function of folic acid has been implicated by dolutegravir use, altering folate's biological action and its metabolism. Low levels of folate are associated with severe birth defects, and therefore, periconceptual administration of folic acid helps prevent the occurrence and recurrence of many congenital anomalies. During pregnancy, folate plays a critical role for maternal health and fetal development, and its requirement usually increases from 400 to 800 micrograms per day. Although DTG is shown to be a safe, well-tolerated, and an effective treatment for HIV, its safety in pregnancy is not well established, and additional studies are warranted. The combination regimen of DTG plus tenofovir emtricitabine or TDF-FTC is a commonly used regimen globally, including in pregnancy. Although reproductive toxicity studies for DTG were conducted on rats and rabbits, and while some defects were reported, these were deemed not to be DTG related. Moreover, the studies were done with doses of DTG yielding higher than clinically relevant plasma levels. They were not administered throughout the entire pregnancy and were not administered as part of a combination regimen. Nutritional animal models are essential to understand human diseases. Hence, we perform DTG fetotoxicity assessment studies on C57 black 6 mice that were fed with a folic acid sufficient diet or a folic acid deficient diet. Our aim was to shed insight on whether folate status modifies the risk of neural tube defects and other birth defects associated with DTG. We hypothesized that perinatal DTG plus TDF-FTC exposure from conception at a clinically relevant dose may alter fetal development, and the absence of folate will increase the incidence rate of neural tube defects and other congenital anomalies. In our treatment regime schematic, we have two diets, folic acid sufficient diet and folic acid deficient diet. In the first schematic, C57 black 6 mice were fed ad libitum on the folic acid sufficient diet, identified in the brown color, and were allowed to mate. But in the second schematic, C57 black 6 mice were fed ad libitum on the folic acid deficient diet for 2 weeks, identified in the orange color, prior to mating, and were continued on the diet. On the day of the plug, identified by day 0.5, we randomly assigned mice to either the DTG plus TDF FTC arm or the control arm, given water, both administered daily by oral gavage. On embryonic day 15.5, dams were sacrificed and fetuses were harvested, photographed, and fixed for further histopathological analysis. Litter size, fetal viability, number of resorptions, and fetal and placenta weight were also recorded. In the folic acid sufficient diet, the number of control litters were 91, yielding 747 fetuses, and in the DTG TDF FTC arm, treated litters were 150 dams, yielding 1,174 fetuses. In the folic acid deficient diet, the number of dams in the control arm are 103, yielding 756 fetuses, and in the treated arm, it was 106 dams, yielding 776 fetuses. The data from the folic acid deficient diet are not yet published, and we're still collecting data. Each fetus was evaluated for gross anomalies by reviewers blinded to treatment allocation. We looked for anomalies in the brain, neural tube, abdomen, craniofacial, eye, limb defects, skin, tail, and body symmetrical defects. We also scored fetuses for bleeding and vascular defects, edema, liver size, growth retardation, and turning defects. We found no significant differences in the litter size or the viability rate, but the resorption rate was significantly higher in the DTG plus tenofovir and tricidobine arm compared to the control. We found no significant difference in the litter average placenta weight, litter average weight of fetal to placenta ratio, and percentage increase in maternal weight. We found a significant decrease in fetal average weight in the DTG plus tenofovir and tricidobine arm compared to the control. In the dams fed folic acid sufficient diet, we found no neural tube defects in the control group, but 5 dams in the treatment group had neural tube defects for a rate of 0.47%. The first fetus was non-viable and displayed exencephaly. It was growth retarded, hemorrhagic, and had a kinked tail. The second fetus was non-viable, demonstrated exencephaly and holoprosencephaly. It displayed bilateral anophthalmia and mandibular aplasia. The third fetus was as well non-viable, growth retarded, displayed forebrain angiogenesis as seen in anencephaly. The last 2 fetuses were viable and both displayed spinal bifida, which was further confirmed by histopathological analysis via H&E staining. In the dams fed with a folic acid deficient diet, we observed neural tube defects, other anomalies, and an increased incidence of turning defects that we never saw in the treated folic acid sufficient group. This is a control fetus shown in the right, left, anterior, and posterior plane. The first fetus here displays encephalocele, which forms as a result when the bones of the skull do not close completely. The next fetus shown here exhibits extreme turning defects and gastrocesius. We also saw fetuses with mandibular aplasia, curly tail, and fetuses with severe edema. It is important to note that several fetuses fed on the folic acid sufficient arm or the folic acid deficient arm displayed anomalies similar in both groups. Compared to the control, fetuses in the DTG arm had anophthalmia and microphthalmia. Mandibular defects were only seen in the DTG arm. We observed fetuses that had severe edema, vascular bleeds displaying a petechia-like pattern. Fetuses were also hemorrhagic, and some fetuses displayed cranial and spinal bleeding patterns. We found that eye defects, edema, and vascular bleeding patterns, including cranial and spinal bleeding patterns, were significantly higher in the treated group fed on the folic acid sufficient diet compared to the control. Fetuses in the DTG arm fed on the folate sufficient diet also displayed a high rate of enlarged liver compared to the control, but this did not quite reach significance. We as well saw hind limb defects such as shortening of the limb. Tail defects were also observed, where we found fetuses with kinked, curly, and flexed tail. As well, we saw abdominal defects. In summary, our data suggests that fetal anomalies are more common in fetuses exposed to the clinically relevant doses of DTG plus tenofovir emtricitabine, supporting a link between DTG use in pregnancy and adverse fetal outcomes. The neural tube rate of 0.47% in the DTG plus tenofovir emtricitabine arm, fed on a folic acid sufficient diet, is similar to the neural tube defect rate seen in the Botswana study. We are currently analyzing the effects and the rate of neural tube defects and other congenital anomalies following DTG plus tenofovir emtricitabine exposure from conception in the presence of a folic acid deficient diet. We will further look into the pathophysiology of turning defects found in the folic acid deficient group. Further studies are also focused on determining the rate of congenital anomalies following other insties exposure from conception. I would like to thank CAHR for providing this virtual platform to present my findings and my viewers as well. I would like to thank the Sagidas team and all the funding agencies and collaborators. For any questions or feedback, please do contact us via the emails provided below. Now I will be happy to take some questions.
Sorry. Sharon, we lost Sharon. Okay, thank you for your presentation. I'm sorry about the mix-up in the introduction. They can't use a Zoom chat, so only the on-air chat. Okay, so that might be part of the reason we're having trouble seeing questions. We'll have to try to have a way of fielding those because it's hard to manage both of these things at the same time. So very interesting work. It's a follow-up from your work that you presented previously, I think last year, and really takes it a little bit further. I've always been struck by the number of abnormalities in general that you're observing in these fetuses across both, as you mentioned, exposed fetuses. And do you have an idea whether you think that this is in particular of this model versus a real impact of the exposure to the drugs?
So the numbers that we do is trying to evaluate a clinical situation. So ideally, the numbers we got with our first published paper is 5 neural tube defects. So it was similar to what we saw with the Botswana cohort. And it's more realistic because we are doing that many dams in order to power our study. And therefore, no matter how many dams we do, it's something that we can actually connect and relate it to a clinical setting such that whatever findings we receive can be extrapolated. And it's a confirmed finding such that we're not doing like n is equal to 20, we're doing more than 100 dams. So, and even even an incidence of identifying like 4 fetuses with fetal anomalies still provides a significant finding that should be shared to the target population.
And it's Sharon, to follow up on that, are you going to look at the folate rich and folate deficient diet, but leave dolutegravir out of the equation as a control?
So in our group, we do have a folate control, which is without the drug, in our folate deficient diet and our folate sufficient diet. So it does not have dolutegravir. So the control group is just being gavaged water.
And I guess similar to that, Marianne Harris has been asking, she can't remember, but or she might have missed, whether or not you did models where you gave dolutegravir alone as opposed to combined dolutegravir with tenofovir FTC.
So we do have concurrent cohorts going on. So we do have another cohort where we're just looking at dolutegravir alone, but we are just analyzing the results and do not want to comment on that.
Okay, and I think one last question from Nadine Crontley. Can you explain how you decided on a 2-week lead-up period to mating with folate as opposed to a longer time on folate?
So previously, prior to these studies, when we worked with a folic acid deficient diet, we did work with them on a folic acid deficient diet with and without antibodies. During that stage, when these mice are on a prolonged exposure on a folate deficient diet, we tend to see there's an increased incidence of fetal anomalies. So comparing with past studies that have already been published, 2 weeks was the accurate amount of time that is required to put them on a 1-month period, minus 2 weeks and plus 2 weeks from conception. So from lessons learned from our pilot studies, we decided that 2 weeks is the right exposure to give them prior to mating.
And one last question has come in, so we'll just finish with this one from Stefan. He was wondering whether there's a variation in folate uptake or absorbance, and if you could link this with neural tube defects in the folate group. Not quite sure I follow that, but.
So from our initial publication, we did identify that there was a decrease in folate levels in the maternal dam, as well as there was an increase in total folate in the fetuses. So that was just basically looking at the folate levels in the dams and the fetuses, but we're still trying to use this cohort to elucidate more findings of how we can actually connect how DTG can actually be associated with folate metabolism.
Thanks again for this really elegant work. I'll pass it over to Sharon to introduce the next presentation.
Thank you.
Okay, thanks, Marina, and hope we're all in order now so we don't introduce the wrong person. So our next speaker is going to be Elizabeth King. She is the Mark Wainberg CTN Fellow, and she is going to present on the progression and severity of menopausal symptoms for women living with HIV. Welcome, Elizabeth.
Hello there, my name is Dr. Elizabeth King, and today I'm excited to share with you some research that I've been doing with Dr. Mona Lutfi and Dr. Melanie Murray on understanding the progression and severity of symptoms for menopausal women living with HIV. Before I begin, I'd like to gratefully acknowledge that this research was conducted on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. So first and foremost, why are menopausal symptoms important? And so these are important because they really fit at the intersect of 2 areas of research priority for women living with HIV. Now, it's been nearly a decade since the UNAIDS called for worldwide focus on understanding aging for persons living with HIV. But it hasn't been until more recently that the topic of health-related quality of life has really come to the forefront, with recent calls that this should be part of worldwide global targets. Now, menopausal symptoms really encompasses both of these factors, and managing menopausal symptoms will be an important part of preserving health-related quality of life for women living with HIV. This topic is particularly timely because the number of women living with HIV who are of a menopausal ages is increasing throughout the world. In Canada alone, you can see that around 1/3 of women living with HIV are currently of menopausal age, and that number is expected to double in the coming decade. Now, what do we know about menopausal symptoms or menopausal women with HIV? We know that they commonly have symptoms and that these impact their quality of life. In HIV-negative women, we know that symptoms are influenced by a variety of factors ranging from biological factors like hormonal changes to structural and psychosocial factors like substance use and socioeconomic status. However, there's really been little investigation of how these factors might impact menopausal symptoms for women living with HIV. And understanding who's at risk of severe symptoms and when is going to be a critical questions to answer in treating these important populations. So that really sets the stage for our study aims. Our first aim is to assess menopausal symptoms in women living with HIV in Canada. And our second is to examine the factors associated with symptom experience. And here we plan to look at a biopsychosocial approach, looking first at the progression of symptoms across the stages of menopause, and then also looking at psychosocial and behavioral factors that might influence symptoms. To undertake this study, we took a cross-sectional approach of a very large Canadian cohort called CHIWOS, which is well known to many of you, which basically recruited women from across Canadian provinces. Amongst these women, we included women who were perimenopausal or menopausal, aged greater than or equal to 40, and cisgendered. We excluded women with abnormal menstrual patterns because we depended on menstrual cycle definitions for menopausal stages. We then asked women if they had been having symptoms over the last 2 weeks, and we asked about a number of symptoms listed there, and we rated severity from 0 or no symptoms to 3 or severe symptoms. And we also looked at this on a composite scale from 0 to 21 with all of these respective symptoms included. So what did we find? We found first and foremost that our cohort we think is quite reflective of menopausal Canadian women living with HIV today. We included a total of 457 CHIWOS study participants, and many of them had 2 different observations, so we had a total of 703 observations. The mean age of the women in our cohort was 55 years, and the ethnic distribution was highly representative of what you'd expect in many parts of Canada, with about 50% Caucasian, a quarter African, Caribbean, and Black, and 15% Aboriginal. Overall, the majority had well-controlled HIV parameters, with many of them being on antiretroviral therapy, viral load suppression being common, and CD4 counts often being greater than 200. When we looked at menopausal symptoms in this group, we found that the proportion who experienced symptoms was very high. When we looked at those who had at least one mild symptom, almost 90% reported having one mild symptom or more. And when we looked at one severe symptom, then this went down to around 55%. Now, what did the breakdown of symptoms look like? So some of the most common symptoms were joint and muscle aches, depressed mood, and hot flashes. And then when we looked at the time when women are most symptomatic from a hormonal standpoint during perimenopause, we found that up to 50% had moderate or severe hot flashes. We went on to look at how symptoms were experienced with regards to menopausal stage. And I'll share just briefly some of the most important findings we had here. So what we looked at was we looked at how symptoms varied with menopausal stage, and we found that hot flashes and irritability were the symptoms that were most influenced by menopausal stage. But what we found with hot flashes was really interesting because what we found was that during the first 3 phases of menopause, the proportion of women experiencing moderate or severe symptoms, which is in green and blue respectively, remained relatively stable. And the proportion didn't really fall until women were looked at greater than 5 years in menopause. And so to us, this suggests that symptoms are likely to persist for many years well into the onset of menopause. Then as our final goal, we looked at the psychosocial and behavioral factors that were associated with menopausal symptom experience. Here we did a multivariate analysis looking at those factors that were associated with symptoms, and there were 3 main factors that emerged as the most significant influencers. We found that recreational drug use and depression were associated with more symptoms for women. And interestingly, we identified that resilience was actually protective against severe symptoms. And we were the first group to really look at this. And so we thought that this was a noteworthy finding. Now, resilience is something that really is coming into the forefront for health in general, but particularly health for women living with HIV, with regards to all of the layers of oppression that many women living with HIV have overcome. It's specifically defined as patterns or processes of positive adaptation. And we think that this is going to be a really important area to move our focus towards, and potentially to foster and empower women to have more resilience, particularly during menopause, and integrate that into our treatments. So in summary, our key findings were that we found that the majority of women living with HIV experience menopausal symptoms, and that hot flashes tended to persist well into menopause, up to 5 years in menopause in general. We found that menopausal stage and psychosocial factors influence menopausal symptom experience, and that resilience seemed to protect against severe symptoms. Taken together, I think we have a number of findings that can be applied to clinical practice. First and foremost, we encourage clinicians to ask about symptoms early on and ask about them regularly. We also encourage treating early, as these symptoms aren't likely to resolve on their own. And finally, to adopt a multidisciplinary approach to address different aspects of women's care in managing symptoms. So this study does have some limitations which we'd like to acknowledge. The first one is that not all symptoms that we assessed may be attributed to menopause itself. And so in future studies, it would be important to enroll a premenopausal group and be able to compare that for baseline symptomatology. In addition, we included women who were on treatment for their menopausal symptoms. Although this frequency or the number of women was relatively few, this may have caused us to underestimate the symptom prevalence and severity a bit in our cohort. In terms of areas for future investigation, we think that there's a lot of interesting questions that remain to be answered in this field, particularly in treating menopausal symptoms and current treatment strategies that are being adopted and how we can improve upon this. We also are planning on looking at symptom progression and comparing this to HIV negative populations to find out if women living with HIV are having a unique menopausal experience. So with that, I'd like to close, and I'd like to thank you for your time and attention today. I'd like to give a warm thank you to my supervisors, as well as the CARMA and CHIWOS and BCC3 study teams, without whom this project would not have been possible. Thank you.
So thanks very much, Elizabeth. I've had the opportunity to hear this at the Women's Conference last week as well, and that led to a lot of discussion. And I think, did your survey follow up on, given the fact that so many women had a lot of symptoms for a long time, how many of them did approach their care provider to help, and how often was that refused, or do you have that information?
Yeah, great question. We do have some preliminary data that does look at this, and it looks like very rarely, while about 50% of women had discussions about menopause with their care providers, and this is of a group of perimenopausal and menopausal women who are age 55. So it's quite surprising that these discussions weren't had that frequently. In addition to that, we do have some preliminary data that suggests that the treatment of these symptoms is that these women are quite undertreated as compared to what you would expect with the frequency that we're seeing symptoms. So so some interesting findings that are kind of in the works, but certainly it seems that we could do better as care providers in asking women about these symptoms.
Right. And another comment from the other postmenopausal woman in the group here, from Marianne Harris, is thank you for your presentation, but recognizing that the limitation is without an HIV negative control. So really, is this any different in terms of the percentage or the severity? She remarked particularly on the fact that this lasted for more than 5 years seems a bit unusual.
Yeah, I think that is a very important point and a very important question that in my mind still remains quite unanswered. When you compare our numbers to populations of HIV negative women, the numbers are higher, but that's also not accounting for and controlling for a lot of the psychosocial factors and structural factors that we found associated with more severe symptoms. So in order to really do a comparison, you need to control for those factors. There are some studies that look at a limited group of women living with HIV. So for instance, just women who have substance use and are living with HIV. And when they control for those factors, they show that the severity of symptoms was not significantly different. But we're still missing that kind of study in a larger cohort of women living with HIV in general. In terms of the duration of symptoms as well, we don't really have an answer to that question. In HIV negative groups, on average, it would be 4 years. So this might not be too far off from that, but we do plan to look at the progression and compare it to a Canadian HIV negative cohort to try to answer that a little bit further.
Great, thanks so much, Elizabeth. I think we're going to move on now in the interest of time, and I'm going to get a second chance to introduce the speaker I already introduced, who has now fortunately been able to join us since the internet connection has been reestablished. So this presentation is by Tivani Mashamba Thompson, who comes to us from the University of Pretoria in South Africa, who's going to speak on co-creation of HIV-ST delivery approaches for improving urban men's engagement with HIV services in eThekwini district of KwaZulu-Natal nominal group technique. It's a big mouthful. So welcome and thank you for joining us.
Good day, ladies and gentlemen. I'm Tivani Mashamba Thompson. I'm here to present some of the results from the fellowship study that I'm currently working on. I'm one of the CTN fellows under the mentorship of Professor Lehane Tabane and Dr. Richard Lessels. The title of my presentation today is Co-Creation of HIV Self-Testing Delivery Approaches for Improving Urban Men's Engagement with HIV Self-Services. This study was conducted at the KwaZulu-Natal, South Africa. Here's the outline of my presentation. I'll present the background and rationale to this study, the methods for the two phases of my current study, also present results of phase 1 of the study, and discuss these results and present the conclusions. I'll also talk about the limitations that we came across in this in completion of this study and how the limitations were overcome. I will then present the way forward or the next step for the current study. Recent research show that across sub-Saharan Africa, men that are living with HIV are 20% less likely than women with HIV to know their status. And this is a major public health problem because, as we already know, we all know that knowing one's HIV status is the first and most important step to HIV care and treatment cascade. This concern was also raised by the concern about men not accessing the HIV services was also raised by the WHO. They referred this poor uptake of HIV services by populations such as men as a blind spot in the global health HIV response. There are many strategies that have been proposed to help improve uptake of populations such as men, to improve their uptake to HIV for HIV services. And one of such strategies is HIV self-testing. And this strategy was really recommended to help improve uptake of HIV services by populations that are underserved and populations that are normally have limited access to facility-based HIV testing. This strategy, the HIV self-testing, is very controversial, and it's important for it to be tailored for different populations to ensure that it's well implemented. The main objective of this study is to develop an acceptable delivery strategy for HIV self-testing to help improve men's engagement with HIV services. And this is focused on urban men. Here's the method that the methods that we implemented or employed to address our research aim. Phase 1 of the method was we used nominal group technique workshop with key stakeholders, and in this workshop we invited people who have expertise or high-level knowledge of HIV services, and also people with expertise on men's health services, and are also interested in implementing HIV self-testing for men, particularly in KwaZulu-Natal, South Africa, the study setting. The nominal group technique was conducted in 2 of these consecutive phases. The first phase was focused on determining barriers for men's engagement with the current facility-based HIV testing services, and the second phase was aimed at determining strategies for delivering HIV self-testing to help men's engagement with these services. Following the NGT workshop, we plan to employ the discrete choice experiment, which will help us determine the most acceptable HIV self-testing strategy in preparation for the intervention study. The DCE will really help us describe and explain and predict between more than one of the HIV self-testing strategies that were suggested in the nominal group technique workshop. The results of the nominal group technique workshop are as follows. 11 key stakeholders aged between 18 and 60 were invited, participated in our workshop, and most of these were men. The majority of these participants were also employed, but 2 of them were unemployed. 2 out of the 11 were unemployed, and 2 out of 11 were full-time students who were also unemployed. Our participants reported the following barriers to be the most problematic barriers to men's uptake of HIV services in KwaZulu-Natal. So the barriers that received that scored the highest were stigma, ignorance, fear, lack of knowledge of one's use of HIV self-testing kits, and psychological factors. Further results were focused on the most desirable delivery strategies to improve men's engagement with HIV self-testing. And the following strategies were suggested by men. They suggested many strategies, but these are the strategies that received the highest scores during the voting. The strategies were provision of free testing kits, internal motivation strategies, using pubs for distribution of tests, promoting self-testing via social media, using videos for a pre and post counseling, promoting HIV self-testing via media. Following the nominal group technique workshop, we put together the results from the phase 1 and phase 2. The phase 1 where barriers to accessing HIV testing services were presented or listed, and also the second phase where HIV self-testing delivery strategies were also recommended. We put these together and matched them in preparation for selecting the delivery strategies that needs to be further evaluated in a discrete choice experiment as a follow-up to the nominal group technique study. As a discussion, the nominal group technique workshop helped us identify the most important barrier to accessing current HIV testing and treatment services by urban men. It also enabled us to identify priority areas that need to be considered while developing HIV self-testing delivery approaches for these men. It is also help us reveal the psychological factors that also have been shown to be the most important barriers for HIV testing and treatment for this population. It has helped us also better understand the study target population and its complexity. And this was one of the really takeaway something that was like a significant result that we didn't intend for at the beginning. Bearing in mind that we are now going to conduct a follow-up projects or follow-up studies in the middle of the pandemic or during the COVID-19 era, we recommend that the follow-up studies or the intervention that is developed is takes into consideration the SARS-CoV-2 and also the need for SARS-CoV-2 self-testing in the current area. So it will be important to put together a delivery strategy that combines the SARS-CoV-2 self-testing as well as HIV self-testing strategy. And that could also be another approach for helping improve men as uptake of HIV self-testing. Some of the limitations that we experienced are as follows. One major limitation of this study was the advent of COVID-19, and this have really prevented us to even to implement the planned pilot study. We planned to implement a pilot trial for this study. So, intervention studies such as that were really banned for more than 6 months in South Africa. And remember, this NGT study was conducted in December 2019, and then a week later, it was the COVID-19 pandemic was announced, and hence now we are planning to replace the pilot study with the DCE because the pandemic is still ongoing. South Africa is now approaching the third wave, which was which is following a very severe second wave. Another limitation of this study that myself and my South African-based mentor are currently involved in COVID-19 response studies for the country, and I also changed employment from UKZN to the University of Pretoria, but we plan to continue completing this study, and the DCE study will be easily implemented despite all the limitations. So as a way forward, during this phase of the study, we have learned that urban men are not one big monolithic mob, and it's important that we design strategies that are tailored for each subgroup to ensure success. So the planned DCE follow-up study will be focused on determining the most acceptable delivery approaches for both HIV self-testing and SARS-CoV-2 among the different subpopulations of urban men. I would like to acknowledge my mentors, Professor Lehane Tabane and Dr. Richard Lessel. I would like to also acknowledge my funder, the CTN, and for giving me this opportunity to complete this, the postdoctoral fellowship as an international fellow for this period. I would like to also acknowledge University of KwaZulu-Natal to have supported this study and their continuing support for my research career development.
Thank you very much, Divani. That was a very interesting work and very relevant. And I think that idea of tying things also to COVID-19 testing is something that numerous regions are exploring as ways to get people in to test for a variety of STVBIs. I think we're going to have to move on in the interest of times because we are already falling behind and we have many excellent presentations to come. So thank you again. Sharon, I'll turn it over to you.
Yeah, before I go, I would just, Tavani, I would just like to echo that, is take advantage of COVID, and rather than bring COVID testing into this, do it the other way around. Bring your HIV testing into your COVID testing and your COVID vaccine rollout, and you might be able to do it that way. So just a comment.
Thank you.
Okay, so we will move on, and the next presentation is by Defani Isnard from McGill University, going to present on the Camu study. I think that we've heard from the Camu study many times, and so Stefan, we're waiting for an update. Thank you.
Hello, today I present the Camu study that we are developing with the support of the CTN. This study uses a natural approach in order to change the gut microbiota, and we aim to decrease inflammation in people living with HIV receiving antiretroviral therapy. I have no conflict of interest. So in Canada, most people living with HIV have access to antiretroviral therapy and are successfully treated. But we also know that despite years on art, those people have increased risk of developing non-AIDS comorbidities such as cardiovascular disease or bone or kidney diseases. We also know that it's persisting inflammation on art that is responsible for this increased risk of comorbidities. One of the key inducers of inflammation on art is microbial translocation, also known as leaky gut. So the leaky gut is a process by which microbial products in the gut microbiota translocate in the body and induce inflammation. So it's due to the gut epithelium allowing this passage. And we know that in people living with HIV, even after years of antiretroviral therapy, they have signs of leaky gut, and the gut doesn't fully repair on art. So we also know that the composition of the gut microbiota, meaning the different microbes that live normally in our gut, is different in people living with HIV. So this different composition is also associated with the development of non-AIDS comorbidities. So we need to develop strategies to protect the gut mucosa and modify the gut microbiota. We use a natural approach with a fruit as a probiotic. So the nutrient in the fruit should favor beneficial microbes and then protect the gut. This fruit is the Camu. Camu is an Amazonian fruit. It grows in South America. You can find it in Brazil and in Peru. And it's known for its high-rich content in vitamin C and polyphenol. Consumption of Camu is authorized by Health Canada, and you can actually find Camu powder in health store, and they are sold to promote bone health and weight loss. So we were interested in Camu because of work done in a mice model of obesity by André Maret in Quebec. And so they showed that when they fed mice with a high-calorie diet, they developed, they gained weight, had inflammation here in black, a leaky gut. And when they fed, in addition to the high-calorie diet, Camu, they found that those mice didn't gain weight, had reduced inflammation, and had no sign of leaky gut. And they also showed that this protection of Camu is due to modification of the gut microbiota with an increase in beneficial microbes such as Akkermansia mucinifila. And so this microbe is interesting in people living with HIV because it's lacking in the gut of people living with HIV, even those on antiretroviral therapy. So secondly, in tobacco smokers, it was shown that men who were drinking Camu juice for 7 days had decreased inflammation markers in the gut, so decreased CRP levels here, and decreased IL-6. And when they compared men who were tobacco smokers who were taking vitamin C supplements, they didn't see this reduction here. So moreover, our in vitro work showed that Camu can have a direct effect on inflammation. So to mimic microbial translocation, we stimulated monocyte-derived macrophages with LPS. So LPS is a product from bacteria that is a really known inducer of inflammation. So we stimulated those cells for 18 hours and then measured several inflammatory cytokines in the supernatant. When we stimulated with LPS, we found an increased production of IL-6, CXL13, and also IL-8 and IL-10 that I don't show here. When we added Camu in addition to LPS, we found decreased production of IL-6 and almost no production of CXL13. So Camu can have a direct anti-inflammatory effect in macrophages, and it didn't affect the viability of the cells. So we developed the Camu pilot study that will be the first trial assessing the effect of Camu in people living with HIV. And our hypothesis is that by consuming Camu extract in capsules, the gut microbiota composition of participants will improve with more beneficial microbes, and we hope to see a reduced marker of the leaky gut, so reduced microbial translocation and inflammation in participants taking antiretroviral therapy. So we chose a study population of adults living with HIV, taking antiretroviral therapy for at least 2 years with a viral load suppressed below 50 copies per ml. We will include people that have a ratio CD4 to CD8 below 1 because those people have higher risk of inflammation and higher risk of non-AIDS comorbidities. We will exclude participants that are taking medications or supplements that can modify the gut microbiota already. So this Camu study will be a single-arm, non-randomized study in which each participant will be its own control. So after a screening visit, we will ask participants to come for 2 baselines to assess intra-participants' viability in all the parameters we will measure. And then we will ask them to take Camu capsules daily for 12 weeks in addition to their normal therapy. And then we will ask them to come 8 weeks later to assess a carryover effect. At each visit, we will collect blood to assess inflammation markers and microbial translocation. We'll also collect stools to assess variation in the gut microbiota. And in an optional sub-study, we will ask participants to undergo colonoscopy before and after therapy to assess the gut architecture. The objectives of the Camu study is to assess the effect of Camu on, first, the marker of microbial translocation LPS in blood, and then to assess the safety and tolerability of Camu in health-treated participants, to assess the effect of Camu intake on other marker of the leaky gut and inflammation markers, to assess the effect on the gut microbiota composition. And as we also know that persisting inflammation plays a role in the maintenance of HIV-infected cells despite ART, so those cells are called HIV reservoir. We will measure the effect of Camu on HIV reservoir size, both in blood and in the gut mucosa. In exploratory objective, we will use state-of-the-art technique to measure those HIV reservoir size and other markers of microbial translocation. And in the sub-study, we will assess the effect of Camu on the gut mucosa architecture and the cell activation, so the inflammation in those biopsies. We started recruitment in November 2020. We screened 7 participants so far. We had to exclude 1 because they took antibiotic in the past 3 months. So out of the 6 enrolled participants, 1 completed the study and the second one will complete the study this week. The study is going well. There's no serious adverse events that were notified by participants. So we need to enroll 16 more participants to reach the target of 22 participants. And all the participants so far, the 6 participants, chose to participate in the sub-study with colon biopsies before and after treatment. So we expect Camu intake to be associated with an improvement in the gut microbiota composition of participants, and we think it will be associated with a reduction in gut damage microbial translocation markers, a reduction in inflammation, and potentially a reduction in the size of HIV reservoir size. So this pilot trial will provide enough data to calculate sample size for future larger studies in people living with HIV. So I'd like to thank Dr. Jean-Pierre Gautier's team at the McGill University Health Center, our physician and staff from the CVS who are helping us recruiting participants in Montreal, the CTN for supporting the study and supporting me as a postdoc, and the CTN staff are helping us developing and running these studies, our collaborators, and of course all the study participants. And I'll be happy to answer questions. Thank you.
Okay, so thanks, Stefani, for bringing us up to date on your project. I'm sure recruitment in the middle of a pandemic is a challenge, and I'm sure your hospital is no different than ours, then it's restricting our ability to do that. What strategies are you going to use going forward to try and help with that?
So yes, we actually amended the protocol recently to ease the recruitment and remove some exclusion criteria. So we excluded participants that were taking statins because it's known to modulate the microbiota composition. And we chose now to include those people also, and we will compare before and after treatment. We think it will be stable enough, but we choose to change a little bit those inclusion and exclusion criteria to include more people in the study and to be able to have an answer in a shorter time.
On the same vein, you know, and we are looking at the microbiota in the change study, and much of the research we've done suggests that sexual activity might change the fecal microbiota in gay men. And how are you going to control that?
So yes, we have a questionnaire, and we record the sexual preference and sexual practice from each participant. We don't expect it to have a strong influence here because we have a before and after. We will assess the effect before and after, but we will take into account because we know that gut microbiota is many different, mostly in MSM.
Okay, and the last question is from Marianne Harris saying, is there any data on any particular side effects that may happen with Camu at the doses that you're using in your study? And is there anyone that's ever allergic to it?
Yeah, so actually, no, there's really few studies with Camu. So the only thing that health can ask us to be careful, it's Camu is known to have a high content in vitamin C. So we excluded the medication of my interfere with vitamin C, although we have less in Camu than what we have in supplement that you can buy in health stores. So there's no known allergy, but sure we check participants and we be sure that they have no reaction, and they take the first dose on site, the first Camu capsule on site to be sure about that.